The common form of lymphedema that we see in this country, the most common form, is neither primary nor is it filariasis, but rather the kind that is left over as a consequence because somebody has been treated for cancer. And in this case, the event is fairly clearly delineated, and it can affect whatever part of the body is going to be affected by where a surgeon is required to alter lymph nodes, remove them, irradiate them, or do whatever has to be done. In this case, this is a patient that we follow here at Stanford who had malignant melanoma about a decade prior to this picture. It was involving the right arm, and as a consequence, the surgeon had to remove lymph nodes from the armpit region, leaving this man with a mild degree of swelling, which he manages relatively readily. It can proceed very much to the opposite end of the spectrum, where it becomes really a tremendously disfiguring problem that impedes function, that predisposes to infection recurrently, and that can significantly alter the life of the individual. So in this case, we're looking at an example of breast cancer-associated lymphedema. In the cure for breast cancer, very often there is the requirement to remove many lymph nodes from the armpit region, and in the affected individual, this kind of problem can ensue weeks, months, or years later. And here's a case of primary lymphedema, a very rare one. This condition, again, a patient that I follow here at Stanford, this condition is called Agenus syndrome, and it's typically seen in people of Norwegian extraction. It's rare to impossible to find it in this country, but we have 1 or 2 cases. And this condition causes not only lymphedema, in this case of all 4 extremities and the face, but also a rare liver abnormality as well. So again, as we think about perhaps those of you in the room that are touched by this, or people that you know, the common scenario is going to be that of cancer. Cancer surveillance, cancer treatment, cancer cure. Not everybody who is treated for cancer and has lymph nodes removed develops lymphedema. So at this point, we need to think a little bit about who's really at risk, who's at lower risk, who's at higher risk. How do you assess the risk? First of all, let's underscore that despite the fact that your doctors never talk about this, maybe haven't heard about it, know the name but don't know what to do about it, this is a common disease. We have prevalence estimates that suggest that there are 10 million people in the United States who have lymphedema. That means that 1 person out of 25 is affected. That's a common problem. And so we need to recognize that with common problems, we need lots of attention, and we need to address common problems with common solutions. But there's a lot to this question about who gets this. So for example, there are 5 million breast cancer survivors in the Bay Area. And of those, only about 20%, let's say, or 15% or 25%, depending on which estimates you believe, will actually be afflicted by lymphedema. What do we know about who gets it and who doesn't? Well, let me show you this graph, which I think is very illustrating of the problem. This is a study that was published about 7 years ago in the cancer literature, looking at the problem of lymphedema in patients who have axillary lymph node dissection. What you'll notice is that by the end of the period of observation, which goes out to 5 years, if you can read this graph, close to 15% of the operated population develop lymphedema. But I want you to notice 2 things. Number 1 is all of the patients got the same anatomic disfiguration at this time point. Only 15% developed the problem, 85% remain clear. But of the 15% who develop it, it doesn't happen overnight. Some develop it in a month, or 2, or 3, or 10, or 12. Some take 3 years, some take 5 years. And this notion that the problem is anatomically present but does not manifest for months or years or even decades later is part of the problem that physicians face in trying to determine who is at risk. Because when you're seeing a patient who's had the risk-imbuing surgery or radiation therapy and they have a normal limb, Are they harboring the likelihood or inevitability that they'll develop the disease, or are they indeed free of risk and able to live life normally? We know a lot about what is not associated with risk. So of those 15 or 20% of patients who have breast cancer treatment, for example, with lymph node dissection and radiation therapy, we don't always know what puts them at risk, but these are the things we know are not associated. It doesn't matter how old the patient is. It doesn't matter what kind of chemotherapy or other drug regimen we use. It doesn't matter how long it's been since the surgery took place. It doesn't matter what is done surgically to the breast itself. It doesn't matter if you irradiate the breast itself. The total dose of irradiation is not the critical feature. The menopausal status of the patient is not. And if the patient develops arm swelling early on after surgery and it goes away, also that is not a predictor of ultimate risk. So many things we know, but the question of what it is, we still don't know. That's part of my research, and I hope if I get the chance to come and talk to you in 2 or 3 years again, maybe I can clarify that a little bit more for you. What we do know about this kind of lymphedema is that it's chronic. It has a major impact on the well-being and quality of life of the individuals affected. It is frequently misdiagnosed. It's often treated too late or not treated at all. And why is that important? Because there is a good body of literature to suggest that the earlier you recognize and treat lymphedema, the more you can prevent its progression and the more you can prevent the end consequences of having chronic lymphedema, some of which we'll talk about this evening. It becomes even more important when we think about breast cancer as one, perhaps the most common cause of lymphedema in the United States. What we know about what we know about breast cancer is that it's definitely on the rise in the United States, and estimates project that we will have new diagnoses that jump from 185,000 per year at the current level to 420,000 per year within the next 20 years. However, despite the fact that we've made major advances in the invasiveness of the surgery, the invasiveness of the radiation therapy, we have many more therapeutic options, none of that has significantly impacted the new incidence of lymphedema in the treated population, which means by definition we're going to see a burgeoning number of cases unless we find some answers. Well, let me tell you one thing that's on the horizon, at least to help us stratify risk a little bit. This is one of the areas that I'm very interested in research and currently using in our program at Stanford. It's a technique called multi-frequency bioimpedance analysis. And basically what this means is, if you're looking at a patient, let's say if I'm looking at a patient who's been treated for breast cancer, we're worried that lymphedema may be present in a very early stage or about to appear. By historical means, we have no way of making that prediction. But using this technique, if we rely on the fact, as we understand, that electricity travels through water, and lymphedema, in fact, is an accumulation of water in the limb, if we look at the limb at risk and compare it to the limb that's normal, and look at the rate of transmission of a tiny bit of current through the limb, something the patient can't feel, the limb that is beginning to accumulate fluid even before the doctor can feel it is going to transmit the electricity a little bit faster, because you all know you're not supposed to talk on the telephone in the bathtub. It's a good conductor of electricity. And that means that by measuring tiny changes in what's called bioimpedance, we can actually detect lymphedema before it develops, which is a tremendous tool for risk stratification. It uses a device that looks just like this. The electrodes are attached to the skin, just like when you get an electrocardiogram, and the device itself you see in the upper left-hand corner gives us an almost immediate readout, very precise, and can be tracked over time, and is useful not only to predict the development of lymphedema, but probably will be useful to predict the utility of treatment strategies as well. Well, once we exceed the point at which we rely on bioimpedance, meaning the edema is all